Dr. Abdullah Alobaid, a board-certified neurosurgeon and a fellow of the Royal College of the Physicians and Surgeons of Canada. Dr. Alobaid currently serves as a neurosurgeon and neurointerventionalist at the National Neuroscience Institute at King Fahd Medical City in Riyadh, Saudi Arabia. He graduated medical school from King Saud University in Riyadh, Saudi Arabia. Then he completed his neurosurgical training at McMaster University in Hamilton, Ontario, followed by a skill-based neuro-oncology fellowship at the University of Toronto, then a cerebrovascular fellowship from the North Shore University Hospital in Manhasset, New York. And finally, he concluded his training here at Seattle by the Swedish Cerebrovascular and Endovascular Fellowship. He assumed several leadership roles, including residency, training program director, and regional program director, and he remains active in academic neurosurgery with multiple peer-reviewed publications and presentations. Dr. Alobaid is passionate about education, surgical innovation, and advancing neurovascular care. He is a member of several professional societies and continues to contribute to the clinical research while maintaining a strong commitment to teaching and mentorship. We are excited for his talk today on Unruptured and AVMs and how we should approach them. Welcome, Dr. Alobaid. We're happy to have you today, and please go ahead.
Thank you so much, Radwan, for the nice introduction. It's a great honor to be back in the podium with the Swedish group. It's been an amazing experience, and I'm very humbled to be in this meeting in front of Dr. McDougall and Dr. Stephen Monteith and the rest of the group. Hopefully this is going to be a short and nice presentation, and hopefully it will deliver the message that's what aim for. Okay, am my slide clear?
Yes.
Okay, so let's start. Okay, so a few disclosure. So this presentation was prepared by collecting data and also by using AI, and it was presented in the recent Saudi Association Neurological Surgery meeting in Riyadh in February 2025. And it was use AI because it's AI becoming frequent tool these days, and the conference was the theme of the conference was AI, so the AI theme was going. So a brief introduction about myself. I'm currently living in Riyadh, the capital of Saudi Arabia. Saudi Arabia is a 30 million population country. Riyadh itself is an 8 million population city. It's a very big city that's across around 120 kilometer in length and 80 kilometer in width. This is the map of Riyadh showing the extension of Riyadh and public transportation that recently launched. And this is where I work. I work in King Fahd Medical City. It's in Saudi Arabia. There is tertiary care hospitals across the country. Each province or each area has a tertiary care healthcare system that get the referral from the province and sometimes outside the province. The King Fahd Medical City, it's a city with multiple hospitals, including main hospital, neuroscience institute, cardiac center, women specialized hospital, pediatric, children hospital, and rehab building. So to the presentation. So the objective of this presentation is to go together from Aruba, to get out of Aruba, to the real practice when dealing with unruptured AVM. And most importantly is to remove the generalizability or the generalization of AVM treatment. AVM, by all means, cannot be a generalized treatment. Each AVM is unique. Even if they called AVM, at the end of the patient A significantly different than patient B. So introduction about the statistics and the importance of unruptured AVM. So it's estimated to be 15 per 100,000 adult. The risk of hemorrhage, this is a common and known statistics for almost every person who is in this kind of work. It's around 1 to 4% annual rate with neurological complication. The importance of management is to prevent mortality and disability. With each hemorrhage, there is a 10% risk of mortality. So the issue is, although it's unruptured, but if it's ruptured, it can cause a catastrophic event. But it's very difficult when you're dealing with unruptured patient. I don't know if it's like how applicable in North America, but in Saudi Arabia, it's very hard for us to convince a normal talking, walking patient that we're gonna do an invasive procedure for you. We're gonna do catheter angiogram and embolization, radiosurgery, and we're gonna open your head. It's very hard to convince them. It's very important to know when we should interfere and when we should not to, and how do we deliver this message to the patients. So I have few cases here. So this is a 22-year-old young lady who is a medical student. She was having anosmia and she had an MRI, and incidentally, she found to have this AVM. If you see here, this AVM is very eloquent. This is at least a grade 4 AVM based on size, based on location, and based on the draining vein pattern. And it's very dangerous AVM because there is a component of that AVM is intraventricular. So usually, as my mentors here and my expert colleague know, that when you have an AVM that's located in the ventricle, this is by itself, it's a higher risk for rupture. So I don't know if we can have an interaction during the talk. So would anyone do anything for this patient? Would anyone offer treatment for this patient, or would apply Aruba conservative approach for this patient?
I wouldn't operate, but I'm afraid of what the next slide's going to show.
Okay. So Steve, maybe you know about this case, but if somebody who doesn't know about this case, like Radwan, would you intervene with this patient? Would you offer treatment, or would you offer conservative approach?
I mean, honestly, given the patient's age, I would probably consider treatment, but I will discuss with the patient first.
I would say maybe radiosurgery, but it's not going to be open surgery or endovascular.
Okay. All right. So I'm going to leave what happened later on in the presentation. We have the slides that showed what we decide as a group and what really happened to the patients. Okay. So let's go to the next patient. So next patient, this is a 29-year-old young man who is a bus driver. He presents with seizure, and he was referred to me from the Eastern Province, and this is his AVM. As you can see, this is his images. As you can see in the MRI, there is multiple feature in this MRI. So he had an AVM. Location-wise, it's kind of supplementary motor area. Like, technically, you can operate on it. It might have a weakness if it just only limited to that. But the problem is with this AVM, it has a lot of venous drainage and it has feature of venous hypertension. You can see even in the contralateral hemisphere, there is venous engorgement. And in the angiogram, he had a very nasty looking prenatal aneurysm. So this is basically a prenatal aneurysm, and the feeder, they are all coming from the left anterior cerebral artery. And one of them forming this big, huge aneurysm, and then jump into the AVM. And the other one is also jumping into the AVM. And this is the draining vein. And you can see clearly that he has a venous hypertension. His seizure is controlled after Keppra, but he referred to us for the management. So I would ask the audience, what's your thought? Would you offer treatment or would you offer conservative approach?
For me, I would treat that one. I would embolize it and probably do surgery, depending, and unless the embolization was really good, and maybe if there's a small residual, do gamma knife.
Okay. All right. We'll see later on what happened. Any other comments?
I think that sounds like a reasonable plan.
Okay. Sounds good. We'll see later on what happened to this patient. So Radwan, let me ask you a question. What, you're about to graduate now. So what will be your approach to this patient? So first of all, would you treat or not? And if you treat, what's your reason?
Yes, for this patient, I'll consider treatment, especially with the presence of the prenatal aneurysm. That's a high-risk feature. And I would probably consider a combined treatment by embolization with or without surgical resection or gamma.
When you embolize, what will be your main goal with the embolization?
Is to secure the aneurysm, basically. Yeah,
exactly. I think you're right, Radwan. It's basically you have to secure this aneurysm because, like for me, I think if you leave the AVM alone and you just secure the aneurysm, half of the job is done. So we'll see what happened later on after that. Okay, so this is a 16-year-old young boy who present also with seizure, and he's right-handed, and this is his CT scan. Unfortunately, I don't have the MRI, and we have it before, but later on we couldn't do it for a reason that I'll explain later. And this is his angiogram. So as you can see, the AVM is quite compact. Like it's fairly compact. It has a very limited superficial, like two major draining vein. He's 16. His seizure is under control. So what would be the option for this patient?
For me, it's probably radiosurgery.
Radiosurgery alone or radiosurgery with embolization?
Radiosurgery alone.
Okay, but he's 16.
Yep, that's okay. The data from UVA shows that it's safe. If you look at the 187 patients we treated with 30-year follow-up, safe.
Okay, that's good. That's good supportive data. Dr. McDougall, what's your thoughts?
Yeah, I agree with Steve as well. I don't think embolization adds anything to you. It's presumably in his speech area. It's a nice tight nidus, as you noted. So I like the radiosurgery for this one as well.
Okay. All right. So let's see what's happened in the next slides. So a brief description about Aruba. So median follow-up is 33.2 months. Mortality and symptomatic stroke in intervention group was about 30%. In the other side, the mortality and the symptomatic stroke in the conservative group was 10%. The clinical impairment rate was also significantly higher in interventional group compared to the medical treatment. So when this study came, it's blow the community and people, oh, wow, we should not touch the AVM. We should leave it alone. Touching AVM is dangerous. So people was very shocked about the results, and it just caused a chaos in the medical community, not only in neurosurgery, like in neurology and radiation oncology, in almost all the medical community. However, as we know, as we dig into the Aruba and we know about it, we know that there is a lot of flaws about it, and it should not be taken precisely for whatever is said. And this is for the following reason, and I apologize for the busy slide about the critique of Aruba, but I think it's very important to go through it because it will be a foundation for us. Like if you, for example, treat an AVM and then after that a lawyer come later on and tell you why you treat an AVM. You should not treat it. The Aruba said no. So at the end of the day, you will offer the patient the treatment because you all know from a medical profession that treatment is better for the patient based on your experience and based on the other data in the literature. But unfortunately, Aruba is basically sticking there. So you have to know how to defend your decision against Aruba. So I apologize for you guys. I'm gonna go through them a little bit. So first, short follow-up. You can't base a decision for an AVM because the AVM is a lifelong disease. You can't base it in a very short follow-up study. Second, selection bias. Many patients had a small asymptomatic AVM, which may not represent the broader AVM population. Or like myself, I don't see small AVM. All the AVM I see, they are the complex, they are grade 3 and more. I rarely see grade 1 or 2. So they are not the real practice. And they exclude in the trial, they exclude the high risk for rupture AVM. So they've been excluded. You cannot. So that means that if you have, for example, if you have this young man, the 29-year-old, the bus driver young man who has a prenatal aneurysm, or that young lady who has an intraventricular component of the AVM, you can't apply Aruba on them because they have a higher risk of rupture. So you cannot apply Aruba on them because they will definitely have a future rupture. So that's the issues with Aruba, the generalizability of all AVM. The other issues with Aruba, heterogeneity in the expertise intervention. Like some center, they have good experts, good experienced surgeons and interventionists. Other center, they don't. So you can't apply that. Statistical power, sample size was small, about 220 patients. That there was a significant technological advancement. We've been evolved significantly since 2013. Like in 2013, all the technology are improved, the gluing material improved, the catheters technology improved, the embolization, the balloon technology improved, and even the visibility of the image, the technology, the image, the angiogram 20 years ago, quality is not as today. So the gadgets are different than 10 or 20 years ago. Age and long-term risk, real-world practice benefit young patient when treated. Young patient, they will get the benefit, even if it seems to be high risk for intervention, but they will definitely get the benefit if you treat them because they have lifelong, and they have at higher risk to develop the rupture in the future. There was a high crossover rate between the medical arm and the interventional arm, so the comparison wasn't that clear. Limited generalizability, exclude high risk, as I mentioned before, because they exclude the high risk patients, so you cannot generalize it on them. This is very important. Real world studies disagree. Later observational studies from prestigious centers in North America and Europe and across the world suggest that well-selected intervention may still benefit certain AVM patients, especially younger individual with unruptured AVM at risk for the future hemorrhage. So the conclusion of the criticism, the real-world studies argue that Aruba findings are context-specific, are content-specific and may not apply to all AVM patients, particularly young individual, high-risk rupture lesion, or those treated in a specialized center with a modern technique. Longer follow-up and a broader patient inclusion are advocated to refine the clinical guidelines. So I have two studies that I chose from the literature that help to make a decision in post-Aruba era. So this this update was made by Judy Hang and her group. They found that the microsurgery for a low-grade AVM show high safety and efficacy. New permanent deficit is 7.7% of cases over 5.3 years, lower than Aruba outcome themselves. So if you select your patient and you do the intervention, they will definitely have a better outcome than leaving them alone. Radiosurgery reduce stroke risk over longer period. The effectiveness is more pronounced in a small AVM after a latency period. Okay, so we come to the embolization. Embolization, this is, I like their quotes on this. Standalone embolization associated with a higher risk. So the problem is, especially like in areas like Europe and somewhat in Saudi Arabia, if the patient is managed primarily by a person who just do an endovascular embolization, the problem is there is a push to cure the AVM with embolization, and that's not right. That's going to be a high risk for a recipe for complication. So although some people argue that nowadays with the newer technology and the newer techniques, you can reach a cure with embolization with follow-up. However, personally, as a neurosurgeon, I do not advocate for that. I don't think it's the right way. I think you should use embolization as an adjunct for whatever modality you are using, but not the primary source of treatment. Because I've seen it in my practice with myself and my colleague. If you push your luck with embolization, your complication rate will be higher. So embolization is better for an adjunct, like mixed approaches, embolization and other treatment, like embolization for an dangerous area, and then after that, the risk for surgery or radiosurgery. And it showed its improved outcome. Multimodal therapy, combination approach achieve better safety and efficacy. Highlight the importance of individualized patient management and highlight the importance of having a treatment in a center that offer all the modality and offer all the expertise in a multidisciplinary fashion. So they have a management paradigm. Listen from Aruba, avoid overgeneralization of the result. Microsurgery remain the gold standard for low-grade AVM. Radiosurgery suitable for deep, inaccessible lesion. Embolization used as an adjunct. So conclusion, Aruba finding emphasized intervention risk, but had a limitation. Post-Aruba study highlight tailored multidisciplinary approach, focus on a personalized treatment strategy and long-term follow-up. So this is another study. It's a bit weird review. It's done in a very mathematical ways. I'll be honest with you guys. When I read it, I was very confused. It took me a while to understand it. I tried to grasp whatever much I can take. It was done by Mike Timiansky group. So basically, it's a meta-analysis, but it's with a twist. So their objective is to compare the management strategy of conservative management, embolization, radiosurgery, microsurgery, and multimodal approach. Okay, so here is the confusion here. So a systematic review including 25 studies from 2000 to 2023. 24 of them was observational and 1 RTC, which is Aruba, of course. It followed the PRISMA guideline. And the PRISMA guideline, it's a guideline that used to extract data and to do systematic review in a very systematic way. It includes 27 checklists. So they adhere to the 27 checklists to make sure that they select the study based on those 27 checklists. They use something called the frequentist meta-analysis. So to make it short, the frequentist meta-analysis, it's a method to compare treatment options that are not head-to-head compared. Like, for example, if there is a studies, compare A and B, and there is another study comparing B and C. So by doing the frequentist meta-analysis, you're comparing A and C. So you're able to do that. That's the bottom line of it. It has a lot of mathematics and algorithms. I'm not going to bother you with it, but this is what they have done. So if you have something weird and confusing in the next few slides, I apologize for that. The intervention of the studies were microsurgery, embolization, radiosurgery, and multimodality. The intervention were compared to conservative/medical treatment regarding the risk of rupture, the functional outcome, the complication, the mortality rate. So let's see here. Okay, I can't see here. Just give me 1 second. Okay, just 1 second. Okay, yeah. So this is the key finding of the conservative management. Okay, Do it again. You see me now? Is it clear?
Yes, yes, we see.
Yeah. So low risk of rupture. So they mean that rupture because of the treatment. That's what's meant from there, which is obvious. Low risk of complication because you don't do anything for them, so you don't have a complication from a treatment. However, they have higher rate of eventual mortality in compared to others. So those patients who you left them alone, eventually they have higher risk of being dying eventually at the end of the follow-up. So it's basically recommended for asymptomatic unruptured AVM with low risk feature of spontaneous rupture. So those patients, you leave them for conservative approach. This is for the sorry, just the top bar. This is the multimodality. Okay, so it's best for functional improvement and mortality. They found it's the best for both. It has a higher risk of rupture and complication because it involves multiple modalities. Like instead of doing surgery only, doing embolization and surgery and radiosurgery. So in their perspective, it has more complication. To compare multimodality to microsurgery, it had higher complication rate. Based on them, I'm not sure how they reached that, because at the end of that, they said that multimodality has the lower complication at the end and the lower mortality. So I'm sorry for the confusion. So comparison of modality, microsurgery, embolization, radiosurgery has higher complication compared to conservative management. Multimodal offer improve outcome but increase risk. Increase risk because it involves multiple treatments. So treatment choice should be personalized. Conservative management often preferred for low-risk cases. Multimodal approach for symptomatic or high-risk patients. So their conclusion, conservative management minimize risk because there is no intervention. Multi-mode strategy beneficial for selected cases. If only, this is a very important, if only one treatment modality is available. Like for example, you cannot give the patient multimodality. The results are likely to be inferior to the national history. So what does this mean? That means that if you have an AVM, that you cannot offer a stage embolization followed by radiosurgery or surgery, so you're going to do surgery alone, your national history is better by leaving it alone. So if you don't have multimodality, don't treat the AVM. So that's what we reach from that. And they suggest that further randomized trial needed for definitive guideline. So before we go to the cases, any questions, any comments? Dr. McDougall.
I was thinking we should maybe go to the cases. We can discuss it later. I have a rant about Aruba that we can. I don't want to disrupt the flow of your talk with.
Okay, let's keep going. So this is the 21-year-old girl, the medical student. So we have a thorough discussion with her and with her family, and our group, our multidisciplinary group, which involved neurosurgeons, interventionists, neurosurgeons who are purely surgeons, and surgeons who are dual trained, and we have interventional neuroradiologists and radiation oncologists. So we sat together, and the decision at that time, we offered to them targeted embolization and then followed by radiosurgery. What happened is her father refused. Like her father was like adamant that he doesn't want any treatment, and he was very particular that they don't want the treatment. So 1 year later, she presented the ER with rupture. So this is her CT scan when she presented first to the ER. And based on the scan, there was the bleeding ictus was from the ventricle. It was my case. I was on call at that time, unfortunately, and I've dealt with them for almost 6 months. It was a very painful 6 months to deal with, but this is life. What can we do? Then I was trying to target to embolize the apex, the intraventricular component. I went through the MCA branch, and there was one going all the way down to the ventricle. I managed to cast it with preservation of the veins. There was another feeder that going from the lenticular striate. I spent almost half an hour, 1.5 hours to go through it until it becomes spastic. Then I backed up and I stopped. She did well after the embolization. She get extubated after 24 hours from the procedure. She was fine. She was embolating, and she was transferred from the ICU to the HDU, and she was fine. And then after 72 hours from the procedure, she suddenly deteriorates and she has re-rupture again. And then we did for her salvage procedure. We did for her bilateral EVD, and her pupil was becoming dilated, and we did the decompressive craniectomy. And then after that, she stayed in the ICU for a long period of time. She was in a very quite bad phase. And at that time, my plan was, because she has a deficit now, so might as well just go and resect the AVM. It was a very painful discussion. Her father, to be like I don't know, like he was interfering with the management, and he was like sending message to the resident, correct the potassium, correct the sodium. It was absolutely a nightmare to deal with. So it was very difficult for us to treat this patient. Eventually, we managed to re-embolize her again, and it was completely embolized. And then after that, we did cranioplasty, and she's now in some sort of long-term facility. Very unfortunate. It was very sad for her to have this, but and unfortunately, she has very bad infection because her father was refusing us to change the EVD until she had gram-negative infection. So it was a 6 months of hell. Okay, so this is the 29 young man. So our decision was to embolize the AVM and start first with the aneurysm, and then after that do a second stage followed by surgery. So that was the decision. So so this is the first stage of embolization. You can see the cast and the coil filling the aneurysm, and this is the angiogram post embolization. You can see it's gone. And then we brought him again for second embolization. I have to admit, I was a bit greedy at that time. I was trying to devascularize the AVM as much, but I think I did it. I overdid it, and I ended up killing the AVM completely. I was concerned about this cast because I wasn't sure if this is an arterial or venous. It looked like, when we do the CT scan, it looked like a venous. I kept the patient at that time intubated for 48 hours because I don't want him to wake up and explode and causing normal perfusion breakthrough. Luckily, fortunately, he did very well. He did not bleed. He did very well. He did not have any deficits, and his seizure is controlled. So we decided to observe him and do an angiogram in 6 months or to a year, and then monitor the AVM, and might offer him radiation or surgery if it's recur. So this is this young kid. So this young kid, his uncle is a neurologist, and I talked to them. I offered them. I told them that the fact that it's in the left side, it's been there. It could not affect him. It could not affect his speech because his speech could be somewhere else. But it's at risk. But it's the definitive treatment. He still need a follow-up. He might need a radiation if we don't do surgical resection. So his father and his uncle, he came to me. He said, "Listen, we want this AVM to be done. We don't want it to be there. We need it to be resected, and we would like that." So we did for him embolization first, and this is what left from the AVM. Unfortunately, during this embolization, we have the catheter, the Scepter XC balloon stuck inside, so we have to cut it, and so it was left there, and we kept him on aspirin. So then after that, we did the craniotomy and we resected the AVM. So this is what you see here. This is the tail of the catheter inside the artery, and this is the disperse of the cast around the AVM. And this is his angiogram. Immediately, there is no AVM. Unfortunately, he had another angiogram that I didn't have a chance to put it. It looks good. Still, there is no AVM. The kid is doing great. His speech did not affect it. He has a little bit memory issue, but he's working with the occupational therapist to help him with that, especially with his school. But he's happy. He joined. He went to the theme park, and he was asking me that if I did the AVM, can I go to the theme park? I want to really go to the theme park, and he went there and he enjoyed it. So that was a good story, alhamdulillah. So in conclusion, this is my conclusion from what I read and from what I've seen. So unruptured AVM continue to be a challenging pathology. Like it's a very difficult, it's a very challenging. You cannot say red, black or white on it. It's a very gray zone. In my opinion, from what I've seen and what I read and what I've been involved with, in this time era, which is the post-Aruba era, unruptured AVM, they should be only treated and followed at a highly specialized center that offer multidisciplinary meeting and multimodality treatment approach. Thank you so much.
Thank you so much, Dr. Alobaid. That was a great presentation and very interesting cases. While I check for any questions from the audience, I'll ask our faculties for their comments.
Thanks, Abdullah. That was fantastic. I'll reserve my comments and questions. I know Cameron he's just itching to unload on Aruba. I have a similar rant, but I don't want to steal Cameron's thunder. So maybe, Cameron, do you want to kick it off and then we'll continue?
Well, it's not so much thunder, but I was invited to participate in Aruba and in the trial, and I spoke to the principal investigator at the time and about the design of the trial, and basically declined participating because the design of the trial was not rational. It did not reflect how patients were treated. It did not offer patients the best treatment available. So it was an incredibly flawed trial in design and in the setup, and we continued to give oxygen to a couple of trials because earlier on our data was so terrible. We had no data. So I think of the ISUIA and I think of Aruba when I think of really terrible trials that got a lot of attention because they were conducted out of high-profile centers by very well-known, very famous individuals, but they were both very flawed trials, and you can't fix a trial that is badly designed. So, if you take it out of Aruba and go back to ISUIA, there was a selection bias in how patients were selected. They were all aneurysms that were selected by surgeons because they thought they should be managed conservatively, and then they followed them prospectively and said, well, this is the natural history of aneurysms. Of course it's not. It's a select group. And so people, because of the profile of the centers, generalized this and gave attention to and credibility to trials that just didn't deserve it. And I think, we continue to do this with Aruba and with ISUIA. And it's not that they didn't have their value, but they got way more credibility than they deserved. And I think editorials in journals do us a disservice when they publish these trials without sort of forcing them to acknowledge the limitations of the trials. You see some effort to do that in literature nowadays. The last paragraph will talk about limitations of trials. And I think that was badly missing from high-profile individuals who got everything they wrote published, whether it deserved to be or not. So, I think Aruba, as you've very correctly pointed out, for all the reasons you've pointed out, had the limited value of really pulling the chain on some bad practices that were going on. And I think AVM patients were being treated badly And ironically, that's what ended up being in Aruba, because the centers that really were doing a good job of the multimodality treatment didn't actually participate in Aruba.
Yeah, Cameron, I would echo those sentiments. The thing that I found striking about Aruba was when you're looking at a disease process with a 1 to 4% hemorrhage risk, the 30-month follow-up is going to be a problem.
Yeah, I mean, it's a design flaw you can't fix. I mean,
right.
You just can't fix that.
And just to reiterate your point, we use the multimodality treatment, but the number of surgical patients is extremely low, even in low-grade AVMs, which we know can be removed. Grade 1s and 2s can be removed with a low complication rate in experienced centers, and there was very few patients that were treated with surgery. So I'm firmly in that camp as well, but it does come up as Dr. Alobaid mentioned. It does come up in the clinic with patients who are highly educated, and they do their searches, and this is what comes up. So we're having to kind of unwind that data point and sort of explain the criticisms of Aruba to the lay public, which can be challenging at times. But thanks, Abdullah. That was really interesting, and I think it's a really important discussion when it comes to the kind of natural history and management of AVMs. I completely agree with you. The management of these patients should be individualized, and whether it's one person that does everything, as Laszlo Steiner predicted, who of course was the first person to gamma knife an AVM. He used to talk about the triple threat. You had to be able to do surgery, embolization, and radiosurgery. And that can either be as one person or a team of people who are experienced doing those three modalities. But it's very dangerous, as you mentioned, if people are good with one thing. Some of the European centers, everything's embolized with 7 or 8 embolizations, and when something could be managed appropriately with adjunctive radiosurgery or surgical intervention. So I think it's really important, as you mentioned, to have a team of people that are experienced in those three modalities, whether it's individually or as a group, so that the patients are optimally managed.
We have one question here from the audience asking about a patient with uncontrolled epilepsy and frequent seizures. I guess it's probably referred to one of the cases you presented. The question is generally about managing those patients. So an AVM probably in an eloquent area with uncontrolled seizure, what's your approach for those?
Okay, so basically, it has to be clear with the patient. So if the patient is presented with a uncontrolled seizure and the decision to treat the AVM for the AVM sake, for the risk of rupture and the risk of complication from the AVM rupture, it has to be clear for the patient. And it's not for the seizure per se, especially if the seizure is controlled. If the patient, and it's happened to me before, I believe probably 3 years ago, like I treated a right Sylvian superior temporal gyrus AVM. That patient was uncontrolled seizure. So the neurologist who's involving with him, he was giving him 2 medication, and he said, "Hey, you know what? Can we entertain the epilepsy during your treatment?" So for that patient, what we did, we did the adjunctive embolization. At that time, I wasn't. I think it's not 3 years ago. I think it's more before 2020, before I become an interventionist. So my colleague, he did partial embolization to help me for the surgery. So we did the surgery, we split the fissure, and then we resect the AVM completely. And then after that, we use ECOG to record if there any epilepsy area activity. And we found some area of activity in the anterior temporal pole, a bit anterior to the AVM. So I went there and I resected it. And then after that, we surfaced the brain with the strip electrode with the ECOG, and then we found no epileptiform activity. And patient did very well. My last follow up with him, haven't seen him for a while, but I'm trying to remember. Believe he was an anti-epileptic for 1 year. Then after that, the neurologist tapered it, and he managed to live without anti-epileptic anymore. So if the surgery aimed for epilepsy, so you have to deal with it as an AVM, and also if you don't have the experience, you have had to ask your epilepsy surgeon colleague to help you with to deal with the epilepsy part of it.
Thank you. I don't see any more questions in the chat. I think there is a comment from one of the audience about multiple AVMs, and what's your approach in those cases, if they're unruptured or if they're unruptured? Yeah.
Well, multiple AVM, I would like, it's a very tricky concept, because AVM generally it's a well-defined structure. If it's becoming multiple, then you start to think about some syndrome, like for example Sturge-Weber or any other neurovascular syndrome. However, if it's true multiple AVM, I think you should be more toward conservative treatment, or at least targeted embolization. That's what I will do. If any other suggestion from Dr. Stephen Monteith, Dr. McDougall, or Dr. Lowe, or Dr. Timchak, would like to hear their opinion about that.
Yeah, I mean, I think, if the multiple, like AVM, I think we're talking about AVMs at different sites. I think, again, you have to treat patients individually. If they're surgically accessible and you can get them in one craniotomy, those are things you want to consider, whether they're suitable for embolization. Radiosurgery, you have to look at the total cumulative dose, for instance. Do they have to be staged? Stage radiosurgery, something that we do. Typically, we give 6 months before we do the second stage. So I think you have to really individualize the treatment, and it may be embolization or surgery for one of the AVMs and then radiosurgery or something else for the other. But it's really individualizing the care and thinking of the whole patient. What order are you going to do things? Putting the frame on after you've done a craniotomy, and then you have to do some wacky thing with putting the gamma frame on or something like that. That can be a challenge. So you need to think about the overall strategy before you start putting holes in people's heads.
You'd also want to think about hereditary hemorrhagic telangiectasias, multiple AVMs. Usually those are sort of small micro AVMs, but seems like a bit of bad luck to have 3 AVMs.
Thank you, everyone. I have one more question before we conclude. What's your experience, Dr. Alobaid, with gamma knife surgery in Saudi Arabia in terms of availability and frequency of use?
Oh boy. So gamma knife, I don't know, like what's the real deal with gamma knife? Like, to best of my knowledge, there is only one machine, and it's very outdated. It's in the military hospital. And the problem with the gamma knife, like most of the hospitals, when they look at a machine, they look at the cost and said, you know what, why I buy a gamma knife for a certain area while I can buy a cyber knife for the whole body? So the problem is, like, it's not very widespread. most of the AVM, or actually pretty much all of the AVM in Saudi Arabia, they are treated with LINAC method, in particularly LINAC. Like, for example, in our center, we were about to purchase CyberKnife, but it get the hiatus with the COVID, so we'll stick with the X-Knife, which is LINAC based. Other hospitals, some of the other tertiary hospitals, they have CyberKnife, and they are using it. I have a question here to Dr. Steve Monteith, and especially Dr. Monteith, you have a wide experience with radiation treatment for AVM. What is the rule for proton beam for AVM? Has any publication about it? Has anyone tried it for AVM?
Yeah, I think that, I mean, the data is way less, right? So, you know, we have data for Gamma Knife in particular, and then linear accelerator based systems, you know, later on. But Gamma Knife, we have the most data. Proton beam, some people have tried it, but you know, there's issues with targeting. You have to put the little beads in, and you don't have the same ability to co-register the angiogram. So for me, the important things are being able to visualize the AVM nidus in a very detailed fashion. And sometimes it's easy and the MRA is perfect and you can do the whole planning basically off the MRA, and the angio is confirmatory. But other times, sometimes you can only see these things clearly on the angio, and if it wasn't for the angio, your targeting would be off. There are some nice ways of targeting now with 3D rotational angiography and CyberKnife, for instance, that can be helpful for targeting. But the Gamma Knife, with the sort of being able to overlay the 2D angio on a 3D volume, it's a kind of an old school technique, but I've found it to be very helpful in terms of targeting. And if you look back at Steiner's data going sort of all the way back, that was one of the sort of big things, was actually being able to visualize the AVM. So if you look at some of the failures, you know, what he stated is that some of that issue was the targeting, meaning you missed a little piece of AVM because you didn't sort of see it appropriately. With the advent of MRI and co-registration with MRA, etc., that improved. But that's what I'd say. You know, proton, I don't think it's it wouldn't be how I would treat my AVM. There are still some people that do it, but it's really the targeting, I think, is the key thing. You really need to be able to see what you're treating, particularly in eloquent areas or small AVMs.
Thank you, Dr. Monteith. I don't see any more questions in the chat.
Great. Well, I think we're at time. Abdullah, it's always great to see you. You put on an amazing conference in Riyadh. I had the pleasure of visiting Saudi Arabia for the first time recently, and Abdullah was the scientific director of that conference, national conference, and it was exceedingly well put together. I'd encourage people to visit, and really enjoyed your talk today. Always good to see you and see how successful you're being in Saudi. And thanks again for taking the time this morning.
Thank you so much, Stephen. Thanks, everyone, for having me today. And it's good to see you, all of you, and hopefully we'll meet again soon.